Good afternoon, everyone. This is Lynette Elliott. I'm showing the top of the hour, so let's go ahead and get started. Thank you all for joining us, and thank you all for being so prompt. This is wonderful. We will go through some brief administrative items first, and then we'll share the agenda and get right to it. So if you can go to the next slide. If you have not been on these calls before, you will quickly find out that we have a very active chat. We really appreciate our participants sharing their thoughts and questions while we go through the presentation. So feel free to post in the chat. You can send it to everyone so that we can all see it and so that other folks on the call can address your questions or comments while we go through the presentation. Next slide, please. Because we are an HL7 project, a fire accelerator project, we do have certain practices that we follow, and this is our antitrust practice. We have included this just as a boilerplate slide in each presentation, just as a reminder. Next slide, please. If you have not joined the project already as a committed member or an other interested party, please do so. We use our member list for email communications and calendar invitation updates. So if you haven't joined the project, you're probably not getting emails from us. You can do it very quickly, and we appreciate all levels of participation. Next slide, please. These are our wonderful project founders and in-kind support sponsors. We can't do this work without all of you, and we really, really, truly appreciate the support and the resources that we've received from these organizations. And if you are interested in supporting the project, if you go to the next slide, we have a link here where you can express your interest on Confluence, or you can email us, either one. And we do share these, we post these slide decks on Confluence following the call, so you don't have to try to, we don't have to try to scribble these URLs down as we fly through these slides. And if everybody can please make sure their devices are on mute so we can cut down on background noise. We also post the recordings. Next slide, please. This is our agenda for today. We will go through a couple of announcements, and then we will share our project roadmap and the upcoming schedule. And then we are going to, Linda is going to update you on the housing data concept submissions. We have received several to date. We're very excited about it, and we really appreciate all of you submitting those things, so she'll share that. And then there will be an overview of housing concepts, and Sarah and our SMEs from Children's Health Watch will walk you through that. And then Lisa will provide some brief updates on the FHIR IG work and what's happening with upcoming Connectathons. And then we will go over what the next steps are for the next meeting. Next slide, please. And at this point, I will hand it over to Evelyn.
Thanks, Lynette. Good afternoon, everyone. Again, we really appreciate your participation and engagement. Great to see the turnout for today. So I'm going to start, just for those that haven't, it's the first time joining us, we shared previously, we have stood up a Gravity COVID page. We appreciate the impact social determinants of health have on COVID responses and the opportunity we have through the Gravity Project to inform the data capture of this data. So we want to encourage those that can, please, peruse the site and post your blogs or relevant information. So this is a way that we can connect the community again from a Gravity data perspective and inform the community at large. And so there's a link there to the page, and if you do want to contribute, you have to set up a Confluence login, and it is free to do so. Next slide. Please keep your phones on mute if you are not speaking. Thank you. Oh, I'm still hearing. I don't know, Lynette, if you want to, in the background, mute people. I do want, because it's upcoming, we have an HL7 virtual Connectathon. Lisa could speak more to it in her presentations, but we want to alert you to the upcoming Gravity Connectathon. But we also have a new, we also have a care coordination track that incorporates the Gravity use cases. So this track is really blends and will build off the gravity testing, so social risk screening, but incorporates ELTSS, home and community-based services assessments, and clinical care plan. So lots going on within care coordination, and we're going to try to test it in the next 2 weeks. We also have a MyHIN Interopathon scheduled as well, so please peruse those sites to join. Next slide. Here's our calendar. So we've kept it, we followed our weekly guidance. So this week, as a reminder, as in red there, it is our deadline for submitting housing concepts, so our housing instability data elements. So if you have not done so already, please do enter your data elements. You could do it through, I think there's slides coming up with the direction of that, but know that you can do it either through an Excel document or through our data element submission tool. But we'll continue us through the, for the month of May. We meet bi-weekly. We'll continue reviewing what is received and also update what findings from the Connectathon. Next slide. Here's our timeline. We're marching through. Again, reminder to everyone, we have 2 streams of work. We have domains. Right now, we're in the middle lane, housing instability. We're working with all of you on data element identification, and then we'll go through coding recommendations. And then at the same time, Lisa and the technical team are developing the FHIR IG and testing it. So these things happen in parallel. So we want to acknowledge the 2 activities. Stay tuned. We'll have another roadmap that will have the value proposition for this work. So I know we have not communicated, what do we get? What does success look like in the end? So that's coming up, but acknowledge that these are our tactical activities, our roadmap until Q1 of next year. We intend to ballot in September and then reconcile and publish a standard for trial use next year. We're also in the process, again, for food insecurity, those that involve that, and Linda could speak to it more, but we want to acknowledge that Linda and Sarah are in the process of submitting all the new codes. So all those coding gaps we identified, we're in the process of submission. So stay tuned for that timeline and that information, but know that our goal is to publish the value sets in VSAC early next year or end of this year. Next slide. All right, so with that, I'm going to hand over to Linda.
Thank you, Evelyn. Okay, so I'm going to walk us through, this is the standard section we have for all our meetings on the update of the data concept submission status. As Evelyn mentioned, we actually have now a total of 10 submissions received. Actually, it's 11 because one came through earlier today, but not in time for the slide updates. So you can see the overall summary of what data elements have been submitted. And 9 of those 10 submissions have been reviewed. So you can see here what we've added to the master list, what have been identified as duplicates as items that are already on the master list, and then some of these other statuses. We still have some outstanding that are on hold where we're waiting for additional feedback from the submitters so that we can complete the adjudication process. And 3 of those 9 submissions have been returned to the submitters with all of the dispositions on the file. This slide is just a reminder, and I put it in here not so much to go through it now, but if you want to, when the slides are published, you can see this. So if you've submitted and you get your file back, you're going to see the dispositions will look like this. And here are the definitions, just so that you get a little bit more information about what those dispositions mean when you get the file back. And here is our list of submitters to date. These are our logos for the organizations who have submitted, and we thank you very much. And as Evelyn said, if you still have items you want to submit, it's not too late. So please go ahead. We'll be happy to take what we can get to add to our information that we've gotten so far. Just a reminder that we're in the phase 1 of the housing domain, where we're focusing on housing instability and homelessness. The bolded items here are the ones where we're really looking for additional information, what kind of programs you you support for housing initiatives and some of the definitional work? What are the applicable intervention activities or services that you provide as it relates to housing? If you look on that submission slide, you will see that screening tools, we've received quite a few screening tools, but we don't quite have as robust a data set for interventions and diagnoses in our goals. So especially in those areas, if you have information to provide to us that can help us with those, please do so. Just a reminder that in a few days, when after the meeting, we will be, Lynette will be sending out the notice for the slides being available in the recording, and then also that the master list will be available, and this one will be updated with all of the submissions that we've reviewed so far. And here's our final reminder again on submitting new concepts to us. You can use the, if you go to this link, you can go to our online tool, or you'll find a spreadsheet that you can download and use that to fill in and send to us. So I believe that is the end of my section. So I'm going to turn it over to Sarah and the Children's Health Watch people.
Hi, everyone. It's Sarah DeSilva here. So this is a point in the project where we have to get a little bit philosophical. So we're going to hopefully have a conversation over the next few minutes about some of the decision points that we have to make when it comes to housing, about the data that we're choosing to build, and then put into history and context with some of the choices we made with food insecurity. Next slide, please. I just want to remind folks about the process that we had to go through with the food insecurity dataset build. For most of June and actually most of July and some of August, a lot of what we were doing was actually refining the definitions of food insecurity and food security collectively in order to make them person level as opposed to population level, in order to make them logically computable by a computable model, to be applicable to FHIR, and to make them inverse of each other so that they so that computable logic could work. So if you remember, we started with the two USDA definitions for food security and food insecurity, which didn't fit into what we needed to represent, and so we worked long and hard to come up with these two definitions. Next slide, please. And part of that process, we went through a back and forth with the community about whether or not we needed to define strata within the food insecurity spectrum for mild, moderate, and severe food insecurity, because initially we did not propose a strata. We just had a food insecurity code, and then the community asked us to represent the strata of food insecurity as defined by the tools such as the USDA food security module and the World Health Organization FHIR tool. And that was in order to better allocate risk. So if you were able to ascertain that somebody was severely food insecure and had no food at home, you could make different choices about interventions than if they were experiencing a different level. And all of that was possible because of a few things. Because there is a gold standard USDA tool. That tool creates a strata, and then that strata was able to be defined and operationalized within our definitions and within our diagnostic approach. Next slide, please. So this is a slide we presented earlier on in our work. So this is a comparison, roughly, of some of the broader domains and the subdomains of food insecurity and housing insecurity. So on the left, you have food insecurity, and we're pulling these domains from the CODES tool and from the World Health Organization and from the USDA and from early food insecurity researchers. So you have this domain of certainty, a cultural acceptability, stability, quality, and quantity. And on the housing insecurity side, you have concepts such as affordability, stability, quality and safety, and quantity. So early on, we tried to conceptualize what the domains or what the diagnoses would be that correlated to those different subdomains. And we hypothesized a housing instability concept, an inadequate housing concept, and then a homelessness concept. Next slide, please. I want to just take us to a kind of a grounding point for the further next conversations we're about to have. There is no set gold standard definition of housing insecurity out there right now. This is just one of many. The reason why I picked this one is because it's actually the closest to what we had for food insecurity, so maybe it'll feel a little comfortable. So this is from Cox et al. So housing insecurity is limited or uncertain access to stable, safe, adequate, and affordable housing in neighborhoods, or the inability to acquire stable, safe, adequate, and affordable housing in neighborhoods in socially acceptable ways. And you can see here, this is the big bucket, right? So housing insecurity is the big bucket, and then underneath it, we have all of these granular terms. Next slide, please. So the problem where we are right now, and the reason why we're having this conversation is for housing insecurity, both the concept itself and its attributes and the absence of that gold standard tool make having a strata or severity strata difficult. We're not at a point where we can say what mild, moderate, and severe food insecurity would be without that tool. There's lots of conversation about that, but we're not there. So we're left with a domain of housing insecurity and then subdomains. And then Children's Health Watch, pipe in at any time. I know we talked about a lot about this. And we're going to open it up to the conversation to the community very, very shortly, because really, this is really meant to be a plumb your wisdom conversation. So next slide, please. So the way, if you look into the literature of housing insecurity and try to parse out the domains and subdomains, you have that broad domain again of housing insecurity, and then there's all these subdomains that are defined in the literature, and then we look to risk within them. So we have homelessness, history of homelessness, overcrowding, doubling up, housing instability, multiple moves, at risk of eviction, behind on rent, and inadequate housing. So one of our attendees, Caroline, mentions there's a squeaky sound. I don't know if it's coming from me. Is everybody on mute?
This is Lynette. Everyone is on mute, and I'm not hearing any squeaky sound.
There's Arizona MO Fellas.
Okay. All right. Got it.
Okay, so the next questions that we have to ask ourselves are, how do we screen for these concepts? And how do we organize them when it comes to creating diagnostic terms? The squeak is gone. Fantastic. Okay, next slide, please. So the first question is, can we screen for them? So over the last weeks, we have been fairly diligent about drumming up all the questions we can find regarding those subdomains. So our screeners, this is just a representation as it stands. We have the American Housing Survey, Housing Insecurity Supplement, which really includes all of the subdomains. We have Children's Health Watch Survey, we have Prepare, we have the Accountable Health Communities tool, or the Neruzaman et al. Tool, which is both in its own tool and represented there. We have the VA homelessness tool, we have WellRx, we have We Care, we have Health Leads, et cetera, et cetera. So within those questions that we have assembled so far in our master set, we have questions on homelessness, on history of homelessness, on overcrowding, on doubling up, on multiple moves, on at risk for eviction, on behind on rent, and on inadequate housing. So can we screen for the subdomains? We can so far screen for those subdomains with the questions and answers that we have submitted. Not to say it's complete, but it's reassuring at least that we've covered all those subdomains. Next slide, please. Now comes the tricky part, right? So if we are not dividing up into the strata, so if housing insecurity presents to us a unique problem where what we start with are really the subdomains. We can see in ICD-10-CM right now and in SNOMED, there are terms for inadequate housing. There are terms for homelessness. in our submission so far, we also have a term suggested for housing instability. We do not yet have a term for housing insecurity, though. So we cannot represent strata, right? We must represent subdomains. The question is, what do we need to say and how do we organize them? Because when it comes to building these kinds of diagnostic languages, we have to respect the taxonomies of the coding systems we're building in. We have to respect those parent and child relationships. So not only do we have to choose what to say, we have to choose how to say it and how to sort it. So this is a rough estimate of what we worked on with SMEs that might be possible yesterday, but you can see everything in parentheses can go up or down. It can go everywhere. Overcrowding is everywhere. So is overcrowding a subdomain of housing instability? Is it its own thing? Is it a subdomain of inadequate housing? In the lit, it's kind of all over the place. And do we need a term for itself, or can it just be contained in one of the parent concepts? At this time, I want to stop talking, and I would love to have a conversation about this concern and how to go forward. And I just want to talk about this briefly because mostly what I want to say is this problem needs the community's help to answer, right? So we need everyone to go out and talk to their housing representatives and their housing folks in their communities, present this predicament, and then come back next time and try to help us figure this out. So I see, so I have a couple questions here. Oh, yeah, so there's a couple things here. So Josephine McNamara talked about how domestic violence is also a housing subdomain. And I'm wondering if you can, so there's a couple different ways to look at that. There's looking at it from the qualifying for housing programs, and there's also looking at it from the being unsafe in your home. So Josephine, would you like to unmute and talk about that for a second?
Yeah, I would say traditionally within the housing scope, domestic violence is usually pulled out because of the safety issues involved in domestic violence and because of the timing involved with domestic violence. Unlike many of the other challenges around housing, domestic violence traditionally is looked at from the housing perspective as not a challenge that can wait. If an individual needs assistance due to domestic violence, then you respond as immediately as possible in order to get the individuals who are experiencing violence out of the house and into something safe.
Yes, and that we recognize that. So the question is, if we can put on our thinking caps, how would we sort it, and how would it be stated?
It would be under housing insecurity.
As its own thing.
Yes.
Okay. I'm wondering if when people feel things so specifically, if you can help by submitting even just that concept in our normal process so that we can start chewing on it. I wonder if folks have a response. I see a couple. I'll make sure, I will promise to get to these things. We have an inadequate housing thread to discuss, and we have an overcrowding thread. I promise I won't forget them, but I wonder if folks want to just discuss what Josephine was talking about. I think we might have to unmute folks on it.
Yeah, this is Anup here. Just I'm wondering, like, given it's domestic violence and it needs to be immediately addressed, does it need to be part of like the housing domain as such? It seems like it's almost like its own thing, independent of the housing security. I'm just wondering, and more of a question to the group, that should it be its own thing outside of housing? It seems to be a solution for a different problem, though it's housing related. But
are you asking for feedback right now, Sarah?
We're asking for a little bit of an open conversation just to brainstorm, and that because this is the topic of the hour because it's pressing. So yes.
Yeah. So my thoughts on it is that domestic violence falls into the personal safety, interpersonal violence category, which is I think recognized as its own SDOH domain, and there are already some, there are some data elements out there that have to do with domestic violence. The hark and the slap are two of them. So my inclination would be to leave that in the interpersonal safety bucket.
And I want to remind folks is that if it's not on this list, it has not been gone through our adjudication process and it doesn't exist per se. So if you have a strong feeling after this conversation, please email a submission. I'm wondering, I see that Susan's commented on some of the HUD categories for homelessness regarding within HMIS. I'm wondering if anyone else has some comments on the IPV element. Understanding that we have two different proposals. One is to create it as its own subcategory, and another is to include it as something that's independently addressed through the interpersonal safety domain.
This is Josephine again. I would honestly state that you probably want to place it in both. I'll tell you that HUD pulls it out separately, even though it's also addressed by HHS, because of the housing dependency, because of the inability to move people from one space into another, unless you're addressing the housing issue. The ongoing domestic violence within a household, when you have an individual who's not willing to leave, is a separate behavioral health issue. When they are ready to leave, it becomes a predominantly housing issue because you've got to be able to move them from one space into another.
I have a question. I'm wondering if a way to phrase this, that specific situation that you're describing is to talk about the concept of being physically or unsafe in your home, which is different than safe housing, because then you could have a concept for the status of being a domestic violence victim or IPV could be in the interpersonal safety section, but then unsafe in home as an assessment would be the specific housing related action item.
I think that would be good because I think there's a number of other situations that could fall under that as well. I think that's a good idea.
Okay, so and I think it's okay to choose. So did everyone hear what happened? Trying to parse out the housing specific element of the situation of IPV, which is again like able to be considered within a housing specific lens, right? And able to be as broad as possible. So that is one option. Thoughts on that?
Hi,
Well,
this is from Arizona.
I was going to say, if you create that option, you can also fall under that individuals who are aging who become unsafe in their home. You can include individuals with developmental disabilities, which are unable to be independent. You can kind of stratify a number of individual situations where persons are not safe within their home.
Exactly. Then we have the problem of having to define it. But that's what gravity does. That's what we do. There were two people talking at the same time. I do want to make sure that we respect. There was somebody speaking from Arizona.
Hi, this is Pam Mosley from Tucson, Pima County in Arizona. I just wanted to point out that in our community, when we look at our data, there are as many people in shelters and as there are in DV provider locations. So the shelters are a place people go to, indicating that they have fled a domestic violence situation. And when there is a domestic violence situation, they usually you just have to split folks up, and it isn't always. Sometimes that's the end of that relationship. And regardless, there obviously there's various complicated scenarios and lethality issues as well that take place, whether the person stays at the residence or not. But our data does indicate there are quite a few folks in shelters and other homeless service provider settings that that aren't necessarily going. I'm sure they're calling the domestic violence provider, but if they're not in a lethal situation, that provider provide them direct assistance. So I guess I just wanted to make sure we understood that there could be there's a spectrum of this, and many of them do fall into the homeless side of things.
Thank you so much. Do we feel like, okay, so we have a proposal to consider, and we can refine this because remember, we're about to go into the end-to-end review process, which allows us to chew on things, whittle them down, like pull things out. But it's kind of important right now, before, like to get things into the master so that we can digest them. So what I'm hearing is a consensus really to focus on the housing specific experience of lack of safety, and then we can collectively craft all the different experiences, like all the different human experiences that would tie into that. Does that seem like a good step forward?
Yes.
Okay.
Yes.
Great.
Yep.
Okay, so I then want to see, because it's 4:30, if I can revisit some of the questions that we saw regarding inadequate housing. So inadequate housing, so one of the statements was wondering whether we should parse out all the next level domains of inadequate housing, like all the toxic bits. And I think we can definitely show that in, the question is whether we need granular level concepts for those small elements, or whether there's other ways to represent them, because we can do, we might be able to do that in different ways. So what are the thoughts there?
Sarah, this is Lucy Johns. Can I speak up?
Of course.
I guess I'm wondering, this has been a really fascinating conversation. I guess I'm wondering how this all ties back to an encounter with a healthcare provider. How much information descriptive of social reality is it reasonable for us to want to extract from a health service encounter? I guess I'm wondering what opinion is on this call about that, because we all obviously are thinking of a lot of aspects of housing that are not ideal, verging from not ideal to really dangerous and have to be fixed like tonight or tomorrow at the latest. I guess I'm struggling with the scope of what comes up when we get into housing insecurity and how much of that is reasonable to be extracting, not to mention acting on within a health service framework.
So I really appreciate your question. Of course, I always do appreciate your thoughts. And I think one of the unique things, again, is that with housing insecurity is that we already have some subdomains, right? So we already have homelessness and we already have inadequate housing. So the question is, and we are stuck, as I presented earlier, not really being able to stratify the same way we did food insecurity. And what we know from action is the interventions on each of these different things is very different. How we intervene in inadequate housing is very different than how we intervene on homelessness, right? So and one of the things we do as a group, and we did this over the course of November and October of last year, is test what needs to be said, say it, and then to say, oh, that's not necessary, or actually that is necessary. So once we get through this brainstorming process, I think we really need to then think about practical use. But right now where we are is we don't have the language to name many of those subdomains at all. they're not contained here, right? So we have to figure out how to fill that gap without creating unnecessary complexity. Difficult.
Also, this is Anup here. Could I add something to that, Sarah, if you don't mind?
Please do.
Yeah, and I think it's the other key aspect of it. I can see, the question is like how much information can you collect in like a particular health encounter setting, and are you overwhelming the member or the patient? Uh, I think as part of this process, it's also about we are defining the data points. We may not be collecting all of these data points in one encounter. And I think the advantage Gravity will give us, let's say, if they did have a social service interaction or something, and if they start exchanging data, this data may become available even before the encounter to, I'm thinking of a scenario where, they are able to share that information with the healthcare provider where they don't have to ask that for that information, but it's available because of their interaction with the uh, social service person or anything. So yeah, all this information may not be collected in a healthcare setting encounter. And I do see, I fully agree, it may be very overwhelming to collect all the level of information we are thinking of. But
Sarah, this is Lisa. I'd like to add to that comment. You made a really important point once when you were talking about the difference between screening and what happens during a clinical encounter when an examination of the patient is being done. And you really distinguished, in my mind, the way you described it as why we have all these screening questions, the sort of the focus of that being very different from, hey, when you're visiting with the patient and they're right there with you and you can apply your clinical judgment to decide whether or not housing insecurity is present or absent, it's a really different situation. I think we need to be clear that when we're talking about screening and when we're talking about observations, clinical findings that would be recorded during a patient encounter.
yeah. No, thanks for, you articulated it much well, much better. No, thanks. Yeah, that's what I think is the crux of the thing. But no, I agree completely.
Can I ask a question of the, oh, sorry.
Sure. No, it's okay. This is Joellen McNamara again. Just to kind of give everyone a little bit of insight, there are particularly FQHCs and hospital systems that are specifically using these ICD-10 codes in particular areas around the country because there are health plans and because there are community-wide partnerships that are already going on. And when we can pull this data from the billing codes, we're able to refer patients and we're able to reach out to patients to start solving these problems. We're already using these. And having definitions and definitive information around this only makes it more timely and it makes it more helpful. So these are already being used. There's already doctors and all kinds of providers, particularly behavioral health providers as well, who want this level of specificity.
Thank you so much. It's nice to hear your voice. I have a question regarding the granularity because I believe that the granularity of what the actual toxin in can be represented with other ICD codes as opposed to just the general inadequate housing code, because you can look at toxic effects of X or Y, or am I incorrect in that? Or maybe what I'll do, I mean, the Donna Ruggs, the HEMA folks, any thought on whether the granular concept of what the actual problem is within the inadequate housing parent, whether it can be represented with other existing codes?
Hi, this is Donna Rugg from HEMA.
I called you out. I'm so sorry.
Okay. I thought, oh my God, she said my name. What was she talking about? The inadequate housing, there's only one code for that currently in ICD-10.
But do we have mold, like all of the other.
There's more than one.
But specifically for if your documentation says inadequate housing, there's one Z59.1 code for inadequate housing, not anything else related if you have other specific issues. So it depends on how granular you want to get. There aren't a zillion of codes that go with housing insecurity overall.
Yeah.
So it's just the classification system based on what exists today. As far as the granularity goes, I think it was Lucy that mentioned this. You know, is it referred to the documentation? I think that's where you have to look. I mean, you can make this as granular as you want, but is it going to be documented? Are you going to get it documented by the providers or the other clinicians that see the patient? If there's an issue, I think it'll come up. I expect in a conversation, but if it's not, then it may exist and you may not know it. Getting them to ask too granular may frustrate them, but again, it all depends on how it's captured and if it's a required field or it's a checkbox that just gets skipped over. So I guess the question that I would throw back to the group is how granular do you want to get? You can get as granular as you want. But as far as is there a code, you can't. So for instance, inadequate housing, that term has a code today, Z59.1. And underneath that includes lack of heating, those kinds of things, restriction of space. So you can get more granular to those subterms that are included in there, but you can't get any more granular in the ICD-10 code.
So I guess we have just talked for half an hour on this, which is fantastic. So this conversation was meant to be exactly what happened, which is great, which is to engage the wisdom of the collective and even just starting to ask these questions together. So I'm going to reframe, because I do want to give Lisa a little bit of time, but I don't want to neglect. If I've missed anything, please let me know. But I'm going to address the overcrowding in my next statement. So everything that is currently black on this slide either exists now in current ICD-10 and SNOMED terminology, or it is part of our proposal already. And I put history of homelessness in there only because that's a history code and that's easy to find. Like that's a different approach. If there is level of granularity that you feel that is all the gray concepts, right? If you feel like they are necessary and they are not currently in our master, we need you to say that they need to be there, right? So this is part of what we do together. And then what we need to figure out is how to organize and define each of the codes and the terms that we're suggesting. So my ask for, and we'll get to this in homework for next time, is to think about this question and get those terms in that you feel like we need on a granular level that can't be collapsed up or collapsed down into a parent concept so that we can start to digest it in our end-to-end review. And where to place overcrowding is a question we have to ask. Like, is it its own thing? Is it part of inadequate housing? Depending on what literature you're using and how it's operationally defined, it is everywhere. And one of the questions I'm going to ask us to think of when we are suggesting concepts is think about what we do when we find it, right? So one of the things that we use to figure out when we need a granular concept is when we do something unique with the finding, right? And this is just what someone was mentioning earlier. Like, there are already interventions happening. Do we need these terms to match the interventions that are happening in the community space with findings in the clinical space? And so there's some questions here. So can we also consider, oh, please do, absolutely. So John Kelly says, can we also consider non-hospital and non-physician venues when we make these definitions? In other words, so that the definitions and taxonomy is reasonably understandable to community-based service-based organizations? Absolutely. And I would say we do not meet our objective unless we do, right? So our goal is to make sure that we're matching how people talk about them across the community. And then Michelle Proser said, hi all, I'm late to the call and have to jump off early. Hi, Michelle, and bye. But I wanted to add the following: despite risking something you already discussed, from our experience, there's a cultural aspect here. We're living with multiple generations in one room is the norm and not considered overcrowding, and speaks to the need for guidance in how we implement screening. Yes, exactly. You know, that's some of what gets parsed out with doubling up and overcrowding in the lit, and I think we'd need to figure that out. Does everyone understand the problem before we segue to the next thing?
So yeah, I wanted to, and this is, just so everyone knows, my background is in housing and community development, so I'm coming at this from a little bit of a different lens. This is Joellen again. I would say, generally speaking, from a housing lens, when you talk about housing inadequacy, you're talking about the physical space of the house. It's either not big enough, or it's, you know, what we call sick housing, which is mold, poor air conditioning, poor air in general. It's something structural about the house that isn't sufficient for what the individuals within the house need. Housing insecurity is based more on the inability to remain housed. Does that help?
Yes, absolutely. Yeah, we did. I think that's a helpful framing. We're really grateful you joined. So how are we doing here? Are we okay to consider this and consider our homework? So if there are terms that the master have to be published, if there are terms on the master that you feel like you need, right, that are not currently on the master, please submit them. And then the next time, and then consider this, take this back to your community, take this back to your homeless organizations, your native experts on the ground, and please help us figure out how we would sort these things and how we will define them as unique, independent, and understandable across community and health system domains. Okay? Right. Okay. I don't think there's yes. Okay, but this is a really good chat thread. I can't wait to parse it out. We'll post a link to the master. So Lisa, are you, next slide, just to make sure that I didn't miss anything, because I probably did. Oh, questions. Okay, good. Okay. Whew. Okay, so on to Lisa for a wrap up on FHIR. And I'm just gonna say, if anybody has, oh, I forgot goals. Okay, I'm gonna quickly go into this one. Housing goals. Next slide, please. This is a very simple slide because there is not very much information on this right now. I encourage everyone to go back and look at the Food Insecurity Master, which you can find on the Confluence, right? The Housing Master will be posted on the Confluence as well, and I'll put it in the chat as well. Right now, our broad goal that we're conceptualizing is that parent, right? So for food insecurity, we had food security as the goal, right? And then we had lots of granular goals regarding decrease in prevalence, screening, intervention, and then there was a generic code for access to food program resources, right? Again, everything in gray we don't have yet. So right now, if you feel like there's the goal space, like what and again, the patient goal, the provider goal, the community goal for the person, if you feel like there are things that are not on there, we need to hear your voice. So again, please conclude this in part of what you bring back before the next session. Next slide, please. There we go. The next slide. Whew. Okay. Passing it off to Lisa.
You did it, Sarah. You did it. Yay. All right. All right, everybody, the closing couple of minutes today, we just give you an update on where we are with the FHIR IG. Next slide, please. We are pressing up against the very, very edge of publishing version 0.0.4 of the IG. I cannot share enough the challenges and difficulties of creating FHIR IGs. And someday, if you get to meet me in Connectathon, I hope you encourage folks who come. We'll share some war stories about the challenges that we've been up against and the team of people who are pressing on with this bleeding edge of creating FHIR IGs. Well, I think my next slide has some timeline things on here. Oh, it doesn't, but we're supposed to publish today, and one of the reasons why I'm so distracted this afternoon is we are not quite published yet, but it is imminent, and we'll probably make some tough calls tomorrow morning and have something published on May 1st. That will be the version of the IG that will go to Connectathon. We are hot and heavy in all of the wind-up towards May 13th. A big virtual event going to be happening. If you haven't signed up, if you have any level of interest, it's a great way to get exposed to what's happening with FHIR and with the development of FHIR APIs in order to share this kind of information. It's going to be virtual. It will be our first time doing a large Connectathon in a virtual way. It only costs $100 for HL7 members. It's $150 for a non-member, and it's not too late to sign up. If May 13th through 15th isn't a good time, there's another Interopathon coming, sponsored not by HL7 but by the MyHIN organization. It's a 2-day event at the end of May, and we'll be doing some similar kind of testing from what we do with HL7. And hopefully in September we'll all be together in Maryland doing this live. We'll see. But in the meantime, if you have interest in learning more about any of these Connectathon testing opportunities, and if you have the kind of interest and sort of technical curiosity to whether this bleeding edge testing kind of experience, we encourage you to check it out. That link on the page right there will take you to the area in the Gravity site where all 3 of these Connectathon testings are mentioned. And next slide. Right now, you can sign up for that May 13th event on the HL7 website. It is up and running. They did offer a general overview course today, just earlier in the day, which you've missed, and we had a good prep session on April 29th to help people get ready and explain about what to expect. But all of those have been recorded, and you can catch those recordings they're posted on the Confluence page. The general one is posted here, and then the specific Gravity ones are posted off from our Gravity Connectathon page. I did want to, yeah.
Sorry, I was going to ask you a question. Are there stakeholder groups that you're missing in representing the complex nature of what we do in those Connectathons so that you can make a public pitch?
We are missing many, many stakeholders. So the sign up is very sparse at this point. I think I have one PMEHR sort of representing a electronic health record signed up, committed to come. We've got 1 or 2 people, well, 3 companies that are going to be doing the patient app and the screening app and working on how to represent these screening tools. But not as many people have really committed to bringing technology to explore how this works in conjunction with the guidance that's available in the IG. So at this point, all the most stakeholder groups that I have represented are patients that want to come and see this done, and folks that are just interested to come and help us document the findings and the learnings from the experience. But we need technology vendors to come and participate. That's the only way that we can know if the IG guidance is sound and going in the right direction. We need real implementers to help with that. So this is my big plea to please sign up and come. If you do, you also have the opportunity to participate in an overarching track called the Care Coordination Track that takes this one step further and looks at how information like what we're dealing with in Gravity can be incorporated and used within larger care planning initiatives, and really look at work that ties all of our conditions, observations, diagnoses, goals and interventions really ties those into thinking about patient care plans. So I encourage you, lots of good reasons to be there. Next slide. While we have been focusing on use case 1 and really getting that ready in the IG that we've been building right now, we have not had as much time to focus on use case 2. We have a little bit of work thinking through the interventions and working with the intervention framework that you guys have all developed, but it's slow going. So primarily our focus has still been on progress on use case 1. Next slide. So you will see that the version 0.0.4 continues to only have content in it relative to use case 1. Any work that we're doing around use case 2, we're building in kind of a separate partition, and we hope to be able to have enough content ready to go that we can merge them together before we go to ballot in the late summer. Next slide. I do not have content today. I promised it last week. I feel bad when I miss a deadline, but the overwhelming challenges of producing an error-free FHIR IG have really swamped us. And we continue to make progress on the referral information and the use of the screen, it's called the service request resource, and ironing that out with our colleagues from the bidirectional service request IG, but it's taking longer than we suspect. So probably won't be until after Connectathon that you see more content from us in that space. Next slide. Yeah.
On the referral on the previous slide,
Yeah.
are you coordinating with 360X so that the demonstration that we all saw at Direct Trust recently in terms of who is referring and how they're referring and what information comes back and all of that, are you?
Yes.
Thank you.
The way
Okay.
that works, Lucy, is that the 360X and the bidirectional service request teams got together and harmonized between those two. So when we're working, but now on the FHIR side, we work with the bidirectional service request, and then they are the ones who really are connected to 360X and the use of direct.
Terrific. Thank you.
Yep. Good work to be connected with. So here's just a couple of links. We encourage you to come and watch, but like Sarah said, if we just have a bunch of human actors standing around and no systems to demonstrate anything, it's not going to be too interesting. So bring your systems, come and participate. You can, if you're going to miss this one in May, you can still sign up, express your interest, give us your email, and we'll connect you for the future events. The middle link, registering for the event, you have to be registered in order to get into the webinars and the Zoom channels where we're going to be discussing and really holding the event. So you need to register. And if you want to get any back prep sessions, they've all been recorded. You can get those at the bottom link on the page. Next slide. Any questions about coming to Connectathon or FHIR IG development?
Lisa, we're so grateful for you. Thank you.
Thanks, Sarah.
Thanks for working so hard out there.
We hope it's going to be thank you. We hope it's going to be a good Connectathon, and I look forward to being able to tell you guys about the interesting things that we learned from the experiment.
Wonderful. And please do try to sign up and go and test the case, because it's only as representative as the people who are represented at the Connectathon. So we hope you all can try to beat the ground and find some of your colleagues to attend. I'm going to close out with homework, I think. Next slide. So please, as mentioned repeatedly in this conversation, we really still want your data concepts. We've worked really, really hard, as you can see, to try to anticipate some of the questions and try to ask the community direct asks so that we can guide submissions. So you can go to the Confluence, and there's a whole data submission process you can find there, either the virtual online tool or the downloadable spreadsheet. You can always send questions to the Gravity Project email, and you always can send questions to me too. Next slide, please. There's always, we try to catch folks up, so everything that we say is is on the Confluence. All of our meetings are on the Confluence. Introductions to concepts and coding systems are on the Confluence. The food and security work is all on the Confluence. It can be a whole weekend of happy reading should you wish to go there. Next slide, please. And then we're still working on the data justice and principles in the background. HMIS work group is kind of sundowning its first use case of presenting a submission and moving on to how to integrate HMIS and HIT in COVID times. There's my email right there. And then next slide, please. Join the Connectathon, we're saying that again. And then please join the Gravity Project as a committed member. We really do, our collective is only, again, as representative as the people who are represented. So if you sign up as a committed member, you'll get all of our emails, we participate in the voting process. We're very, very grateful for all of our members, and we would love to have you sign up officially. Oh, it's 5 o'clock. I do want to say there's a proposal to have the next meeting be 90 minutes long because there's so much to discuss. We wanted to just, if we put it out there, what we're going to try to do is cover everything we can in that first hour. But given that we're grappling with definitions and meaning, it seems wise to extend the meeting time for the next meeting to 90 minutes. And we'll do our best to try to fit it in, but it seems important. Thank you for a very interesting day. We're grateful for all of you.
Yep, thank you.
Thanks, everybody.
Thank you.